I'd like to welcome everybody to the DARIA series, the Drug and Alcohol Research and Innovation Active Learning Network. DARIA is a virtual weekly seminar program delivered by St. Vincent's Hospital, Sydney, Alcohol and Drug Service, and the National Centre for Clinical Research on Emerging Drugs, NCCRED. We do this in collaboration with Southern New South Wales Local Health District, Murrumbidgee Local Health District, Far West LHD, and Western New South Wales LHD. So the aim of the series is to promote innovative practices and share learnings and new ideas amongst clinicians and clinical researchers working in the field of methamphetamine, emerging drugs, and other areas of alcohol and drug health. I'd like to start today by acknowledging and paying our respects to the traditional custodians of the lands and waters of Australia and all the First Nations elders, past, present, and emerging, especially those who may be joining us today. We respectfully acknowledge the traditional custodians of the land and waters and their continuing cultural, spiritual customs and practices. Today, we're lucky to have Liam joining us to present the session this afternoon. Liam is a PhD candidate at the National Drug and Alcohol Research Centre at UNSW, collaborating with NCCRED for his research focusing on methamphetamine withdrawal treatments. Liam is also working as a research officer for the Alcohol and Drug Service at St. Vincent's Hospital in Sydney. His program of research includes a systematic review and meta-analysis of pharmacological treatments of methamphetamine withdrawal. And if you haven't seen that session in the DARIA series, please go back and visit that one. It's on the website. As well as a world-first clinical trial of lisdexamfetamine for the management of acute methamphetamine withdrawal and a novel investigation of sleep during stimulant withdrawal. So today we're going to hear more about this work, and I'd like to welcome Liam, and I'd like to remind everybody that this session is freely available on the NCCRED website and can be disseminated amongst your colleagues, your peers, your friends, or consumers that you think may be interested after the session. So thank you, and I'll hand it over to you, Liam.
Thanks so much, Krista, and thank you for the opportunity to speak today. Today, I will be presenting the results from our, as you said, world-first trial of lisdexamfetamine for the treatment of acute methamphetamine withdrawal, which we lovingly call the OLAM study. Before I get into it, though, I would also like to acknowledge and honour the traditional owners of the land. We will be presenting today from the land of the Gadigal people of the Eora Nation, who lived here and first walked this land where we stand today. We acknowledge that the Gadigal people occupied and cared for this country over countless generations and celebrate their continuing contribution to the life of the region. This study was, for full disclosure, funded by the National Centre for Clinical Research on Emerging Drugs, or NCCRED, who are themselves funded by the Australian Government Department of Health. I am supported by an NDARC PhD scholarship and also by NCCRED, and there are no other conflicts to declare for this presentation. By way of background, methamphetamine use disorder is associated with increased mortality, cardiovascular disease, poor mental health, including issues around suicidality, psychosis, and depression, as well as increased risk of blood-borne virus infection. Methamphetamine use disorder is importantly a global issue. The map on the right there shows you the estimated prevalence of methamphetamine dependence worldwide. And as you can see, Australia actually has the highest prevalence of methamphetamine dependence in the world. It's estimated to be about 0.6% of our population. The harms associated with methamphetamine use have been increasing both in Australia and overseas. And this is reflected in treatment episodes in Australia. Methamphetamine, which is represented by that green line, is now the second most common drug of concern in Australian treatment settings. It accounts for about 28% of all episodes of care in Australia for alcohol and other drug services, excluding methadone treatment. And despite there being no treatments for methamphetamine use dependence or withdrawal, it is still the most common illicit drug that people seek treatment for. Interestingly enough, despite barriers around accessing withdrawal treatment in Australia, it is also the second most common drug of concern in withdrawal settings as well. A significant challenge to treating methamphetamine use is managing the withdrawal syndrome. for which there are no effective pharmacotherapies, and it's usually managed symptomatically. But what is this withdrawal syndrome? Well, once somebody has developed a tolerance for methamphetamine, abrupt cessation of methamphetamine will result in a withdrawal syndrome. This syndrome is broadly characterized by dysphoric mood, sleep disturbance, changes in appetite, and vivid or unpleasant dreams. Importantly to know, though, it's really poorly characterized in the scientific literature. And the largest study that we have looking at the natural history of methamphetamine withdrawal actually only includes 21 people. So the data that we have surrounding this is actually quite weak. That being said, it is thought to appear in 3 broad phases. Initially, there's what we call a crash phase, which appears 12 to 24 hours post last use. However, it may not be present, and this depends on the pattern of use. If somebody is more of a binge crash, then they're more likely to experience the crash. But if somebody uses just a little bit every day, then they're less likely to actually experience this crash. But this crash is characterized by exhaustion, fatigue, dysphoric mood, anxiety, agitation, cravings, and aches and pains. Following this crash is a more typical kind of withdrawal phase, which may last up to 2 to 4 weeks, but the symptoms peak within the first 7 days. This phase is characterized by mood fluctuations, restlessness, irritability, anxiety, poor concentration, really strong cravings for methamphetamine, increases in appetite, and disturbances of thought or perception. After this phase is what we call the extinction phase, and this can last for up to or sometimes longer than 12 months. This is characterized by episodic fluctuations of mood, levels of craving for methamphetamine, and quality of sleep. Importantly, though, while this does tend to be quite protracted, it does get better over time. So it's not constant for the rest of the life. But why is it important to treat withdrawal, especially considering that methamphetamine withdrawal is not usually a medically dangerous syndrome? Well, it's really common. In the first instance, up to 97% of people who regularly use amphetamines will experience withdrawal. Withdrawal and cravings can cause significant discomfort, and this is particularly true in the first 7 days. The severity of these withdrawal symptoms are usually front-loaded in this first 7 days, getting less intense over time. The easiest way, however, to relieve these symptoms is, probably not surprisingly, to use more methamphetamine. What this means is that ineffective treatment of withdrawal symptoms can lead to high rates of relapse, and a reduction in withdrawal or craving severity can lead to better treatment outcomes and increased comfort for our clients. It has to be said that treating withdrawal is not going to solve dependency. It's not going to treat methamphetamine use disorder in and of itself. However, poorly managed withdrawal is a barrier to accessing long-term dependency treatment. So while addressing withdrawal alone may not treat methamphetamine use disorder, it is still an essential first step, which can then allow people to move on to other long-term treatment options. Importantly, there are currently no effective treatments, pharmacological or otherwise, for methamphetamine withdrawal. A recent systematic review and meta-analysis that we conducted, which was highlighted in a previous DARIA presentation, found 9 randomized control trials of 6 medications enrolling 242 participants. The trials looked at mirtazapine, modafinil, ibudilast, amantadine, varenicline, and amantadine. So a wide range of pharmacological interventions. However, all medications that have been trialed to date have failed to demonstrate any effectiveness in managing withdrawal symptoms or cravings. That being said, there is strong evidence for what we call agonist treatment approaches for other substances. An agonist treatment approach, of course, is when you use a similar medication or a similar drug to treat the withdrawal or dependency of an illicit drug. Common examples of this are buprenorphine for the treatment of opioid withdrawal, nicotine replacement therapy for the treatment of tobacco withdrawal, and nambixols for the treatment of cannabis withdrawal. The question, of course, is, has this ever been tried for methamphetamine withdrawal in the past? And the answer is sort of. Dexamphetamine and modafinil have been assessed in long-term dependency trials, both of which are stimulants and act in a similar way to methamphetamine. These trials did find that dexamphetamine could reduce methamphetamine withdrawal severity and craving. However, it's really hard to generalize this to a withdrawal setting because of the nature of dependency trials where people could continue to use methamphetamine outside. There has recently been one study of extended release dexamphetamine for methamphetamine withdrawal, in which they gave 60 milligrams per day of extended release dexamphetamine, and they found reduced withdrawal severity in the first 7 days of withdrawal. There are, however, some pretty significant issues with using dexamphetamine, which we feel could be overcome with a new treatment. And that treatment is lisdexamfetamine. Lisdexamfetamine is what's called a pharmacologically inactive prodrug of dexamphetamine. So what that means is that when lisdexamfetamine is first taken, it's inert, it does nothing in the body. However, once the lisdexamfetamine reaches the bloodstream, it goes through a process called hydrolyzation, where a lysine amino acid becomes cleaved off the molecule, leaving the psychoactive dexamphetamine. And this is the active component of lisdexamfetamine. When we compare lisdexamfetamine to regular dexamphetamine, it has some really great advantages. It's really good for once daily dosing because it's long extended release formulation. It has reduced potential for non-medical use, and this is because the rate limiting factor of its extended duration is actually the chemical reaction that happens in the bloodstream. So even if a capsule was to be broken open and injected or anything like that, the psychoactive effect wouldn't be the same as doing it with dexamphetamine because it still has to go through that process of hydrolyzation in the bloodstream before it becomes psychoactive. It also leads to lower peak dopamine concentrations and reduced mesolimbic positive reinforcement, which is a fancy way of saying high. We know that because of the previous studies looking at dexamphetamine, lisdexamfetamine does have the potential to ameliorate withdrawal symptoms and craving for methamphetamine during the acute phase of withdrawal. So to try and answer the question of can we use lisdexamfetamine to treat withdrawal, we started the OLAM trial. The primary aim of this trial was to determine the feasibility and safety of a tapering dose regimen of lisdexamfetamine for the treatment of acute methamphetamine withdrawal. Because this is the first time this medication has ever been trialed for methamphetamine withdrawal, we had to do a safety and feasibility trial. So that means that we designed an open label, single arm pilot clinical trial, which means that there was one arm, everybody on the trial received the medication, and we all knew exactly what people were getting. And this is so that we could really carefully assess the safety in a small number of people. We conducted this study in the Gorman unit, which is our inpatient withdrawal management unit at St Vincent's Hospital, Sydney, which is a smoke-free unit, as are all public hospitals in Australia, which is, it's important and it'll come up again later. The participants who we enrolled in this trial were over the age of 18 years old and voluntarily presenting to the inpatient drug treatment services at St Vincent's Hospital. Our participants had to be treatment seeking for methamphetamine withdrawal and also meet the DSM-5 criteria for methamphetamine use disorder. To ensure that our participants were right in the acute stages of withdrawal, we also required them to have last used methamphetamine within 72 hours of planned first dose of the study drug. And we confirmed this with a positive UDS for amphetamines on admission. We excluded people who were breastfeeding, people who were pregnant or unwilling to avoid becoming pregnant during the trial. And we also excluded people who had expected concurrent withdrawal from other drugs, notably alcohol, opioids, benzodiazepines, GHB, and other gabapentinoids. We excluded people who had any contraindications to lisdexamfetamine or just in general a medical condition, which in the opinion of a study doctor rendered them unsuitable for the study. The intervention for this trial was lisdexamfetamine. The lisdexamfetamine was formulated in 50 milligram capsules given in a tapering dose. The doses started at 250 milligrams on day 1, reducing by 50 milligrams per day till they received 50 milligrams on day 5. It was dispensed each morning under nursing supervision so that we could make sure that people were taking the correct dose and we could count exactly how many doses were taken or missed. And all participants in the trial could also receive treatment as usual, symptom management and supportive care. The way the trial worked is we recruited people as they were calling the service, seeking admission for methamphetamine withdrawal. So we recruited them primarily through our centralized intake line, but we also picked up people who were coming in through emergency department or our Panda unit. The first day that they came in of admission was called day 0. And that was when we did our screening and baseline assessments. Then days 1 to 5 were when our participants received the study drug. And day 1 was defined as the first morning that people woke up in the unit. Days 6 and 7 were an optional extra 2 days that people could stay in. And this was just to make sure that there was no kind of residual withdrawal or any kind of knock-on effects from the medication, and to allow people to leave the unit completely stimulant-free. We then followed up with our participants once a week for 3 weeks post-discharge. And this was just to see how they were doing, see if there were any adverse events, and track their substance use as well as any kind of engagement in other forms of treatment. Our primary outcomes were feasibility and safety, which we defined as the time taken to recruit and enroll, and also adverse events. We had a whole raft of secondary outcomes, including retention and treatment, which was the proportion retained to the end of treatment, treatment acceptability, which we defined with the treatment satisfaction questionnaire for medicines, as well as medication adherence and requirement for symptomatic medication, withdrawal severity as measured by the amphetamine withdrawal questionnaire, craving for methamphetamine measured by a visual analog scale, psychosis and hostility using a shortened version of the brief psychiatric rating scale, suicidality using the Columbia Suicidality Severity Rating Scale, and substance use post-discharge using timeline followbacks. We initially wanted to recruit a sample size of 15. However, we did curtail this at 10 due to COVID. Adverse events were described by the type, the severity, the causality, and expectedness, and they were all reported regardless of how severe they were, whether or not they're repeated or not, or whether we thought that they're actually related to the study drug or not. We used descriptive statistics and proportions to describe our data, and then we also used some repeated measure ANOVA analysis, and this was to look at changes over time. The study was approved by the St. Vincent's Hospital Human Research Ethics Committee, and all participants provided written informed consent before any study procedures could take place. We also prospectively registered this trial with the Australian and New Zealand Clinical Trial Registry, as all good clinical trials are prospectively registered. So what did we find? Well, of our 10 participants who we recruited, the average age was 37 years old. The majority of our sample, 90%, were male, 4 of whom were heterosexual male, 5 who were homosexual male, and 1 heterosexual female. On average, our participants had been using methamphetamine for 13.6 years prior to their admission to the unit. And over the 28 days prior to admission, our participants used, on average, on 23 out of the last 28 days. And on a typical day of use, would use on average 0.6 grams of methamphetamine per day. And this ranged from as little as 0.2 grams per day to as much as over 1.2 grams per day. So it was quite mixed, but it was quite a high level of use across the sample. The sample was evenly mixed in terms of people who smoked methamphetamine and people who injected. And there was a relatively high level of recent substance use as well. Half of our sample reported using GHB within the 28 days prior to admission, and half our sample reported using cannabis. Notably, though, there was no recent opioid use reported. In terms of feasibility for our trial, we assessed 38 people for eligibility and had to exclude 28 of them. That means a quarter, or 26% of potential participants, could be enrolled in the trial and then were enrolled in the trial. The primary reasons why people declined to participate were because it's a smoke-free environment, and there was an inability to comply with that environment, and also because people were worried that their residential rehabilitation service wouldn't accept them if they were given prescribed stimulants beforehand, and 2 people gave no reason. Recruitment for this study was open for 126 days, which was obviously restricted by the COVID pandemic. But we still managed to recruit 1 participant every 12.6 days during this period. The safety profile of lisdexamfetamine in this population was mild, which is really promising to see, especially given the doses that we were giving them for this study. 1 serious adverse event was reported. However, this was unrelated to the study drug. This was a diagnosis of a pre-existing shigellosis infection. Throughout the study, 47 adverse events were reported, 17 of which were considered causally related to the lisdexamfetamine. The most common issues were gastrointestinal issues, headache, and trouble sleeping. However, all of these adverse events were of mild severity or grade 1. And there were, quite encouragingly, no adverse events related to vital statistics. I've included the graphs here of heart rate and blood pressure over time. And we're really concerned about this because whenever you give a stimulant, it causes hemodynamic changes, and we're worried if we see any kind of spikes in blood pressure or heart rate. And so as you can see, through baseline, there was no real significant change in heart rate and blood pressure. They were highest on admission, which is to be expected. Most people who came into this trial were still under the effects of methamphetamine on their baseline screening. But none of the changes in heart rate or blood pressure were statistically significant. We managed to retain 8 participants to the primary endpoint of this trial, which was day 5 or completion of the medication. 2 participants left the unit early, and both of whom left for legal reasons. They said that it was not related to the study drug, nor was it related to the severity of their withdrawal. We were also able to retain 8 people for the 3-week follow-up period. In terms of acceptability, our participants rated their median satisfaction at 100% at the end of treatment. And this was based on a bunch of different subscales within the treatment satisfaction questionnaire for medicine, looking at global satisfaction, medication adherence, side effects, as well as convenience of taking the medication. Our participants also had 100% medication adherence up to their relative discharge dates, meaning no doses were missed and no doses were refused either. Looking at withdrawal severity based on scores of the amphetamine withdrawal questionnaire, we saw a significant trend downwards across the admission period. Scores started off highest at day 1 and reduced steadily in an almost linear fashion to the end of treatment. Interestingly, if you look at day 6, what you can see is a slight increase in withdrawal severity after we stopped giving the stimulant medication treatment. While this wasn't statistically significant, it is actually something that we see quite often with other agonist medication treatments for withdrawal. So it's something that we did expect, and it's something that we're going to have to look into again in the future to try and control for any kind of rebound withdrawal. Withdrawal severity also remained relatively stable across the 3-week follow-up, despite the fact that some people were, again, using methamphetamine and some people weren't during that follow-up period. Craving for methamphetamine similarly followed, again, a very similar pattern. It started off really high at baseline and then decreased throughout their admission. Interestingly, unlike withdrawal symptoms, there was no rebound effect for craving that we saw in the data. In terms of the other outcomes that we looked at in this trial, there was no increase in any kind of hostility, suspiciousness, hallucinatory behavior, or unusual thought content items over the admission. At baseline, our participants were scoring 6.5 on the BPRS, and they were scoring 4 at the end of treatment. This is a score out of 4, and it's all very mild, but encouragingly, we didn't see any increase. 6 of our participants reported any suicidal ideation in the last 12 months before admission. However, again, very encouragingly, none reported any suicidal ideation during the inpatient period. Looking at abstinence post-discharge, and the way we measured this was by self-report timeline follow-back every week. 4 of the 8 participants who completed the follow-up period self-reported complete abstinence over the 3-week follow-up period. 6 participants were abstinent during week 1, 4 participants were abstinent during week 2, and then 6 participants were abstinent again during week 3. So what does this all mean? Well, findings from this open label pilot study demonstrated that for participants with methamphetamine use disorder who are seeking treatment for withdrawal, a starting dose of 250 milligrams of lisdex was feasible and safe for the management of acute methamphetamine withdrawal. This regimen produced significant ratings of acceptance and retention, and findings also showed significant reductions of methamphetamine withdrawal and craving, and these corresponded with the down titration reductions that were measured through follow-up and up to day 28. There were, of course, some limitations to this clinical trial, notably the fact that it was a single-arm study and it was uncontrolled. What this means is we cannot comment on the efficacy of lisdexamfetamine. We don't know if it works yet. This study was just seeking out to make sure that it's safe and feasible. The safety results from this study were, again, very, they were great to see because we started at 250 milligrams, which is 3 times higher than what has been previously indicated for other treatments. Previous work done by our group has shown that heart rate and blood pressure changes associated with 250 milligrams of lisdexamfetamine are likely quite tolerable and probably won't result in any significant hemodynamic changes. Recruitment feasibility for this study was actually comparable with other studies in the field. And this is despite us having no active recruitment, and we didn't advertise the study in any way. We just picked up people as they were calling the service, asking them if they were interested. The participants in this study who did not progress through to formal screening primarily did so due to a refusal to participate. They didn't want to do the study. We thought that they were likely to be withdrawing from other drugs, so they reported that they used other drugs in combination with methamphetamine. However, really importantly for the feasibility of this and any other hospital-based treatment, 4 participants who are really keen on doing the study, really wanted to do something about their methamphetamine use, actually refused admission to the hospital once they found out that it was a smoke-free environment because they didn't think that they could cope with withdrawing from both methamphetamine and nicotine at the same time. Retention in our study was similar to or better than comparable studies. And ratings on the treatment satisfaction questionnaire of over 80% indicates a greater retention in the study. So that was really promising to see as well. Although withdrawal severity and craving fell through this trial, this was actually expected. Other studies looking at the natural course of methamphetamine withdrawal have shown that symptoms reduce over time in a probably linear fashion. Our study, however, included participants with really high baseline withdrawal symptom severity. It is also important to note the possibility of a rebound withdrawal, which is seen in other treatment modalities as well. Future directions should really focus on assessing the efficacy of lisdexamfetamine, and this can be done through multi-site randomized placebo-controlled trials. Further research is also needed, which should focus on ambulatory withdrawal management applications of lisdexamfetamine, in particular due to its favorable safety and diversion profile and its suitability for once-daily dosing. Such trials could provide an alternative that may not require supervised daily dosing, with a potential for collecting medications once or twice a week, similar to trials of lisdexamfetamine for methamphetamine use disorder, which we conducted as well in St. Vincent's. In conclusion, methamphetamine use and withdrawal is a significant issue, not just in Australia, but around the world. And no medication to date has been efficacious in the treatment of methamphetamine withdrawal. This study examined a novel treatment regimen and found that lisdexamfetamine is safe and feasible for the treatment of acute methamphetamine withdrawal in inpatient settings. More work, however, is needed and is warranted before any kind of efficacy of lisdexamfetamine can be determined. Thank you so much for your time. And before I finish up, I would just like to acknowledge the wonderful participants of the OLAM study for giving up their time to participate in this trial, as well as the wonderful clinical staff at St. Vincent's Hospital Sydney Gorman unit for making this all possible. There was a massive team behind the OLAM study, and I would, of course, like to thank all of them for their continued support through this trial. If you'd like any more information, please feel free to contact me at any time. Thank you.
Thanks, Liam. Thanks for highlighting that. That was a great talk. I really appreciate that. And I'm sure that there are some questions from people who are attending this afternoon. So please feel free to pop your questions in the Q&A, or if you'd rather join the conversation, we're happy to unmute you, and you're welcome to join along and chat. While you're thinking of your questions or typing them out, I'd be interested to hear if there are any clinicians online from the Gorman unit this afternoon who might like to comment on their perspective of the trial, or the participants who were involved in the trial from that clinical perspective. I don't think we have any consumers on the call today, and that would break confidence anyway. But if there was anyone who had anything to offer about those other perspectives, we'd love to hear them. I guess one of the first things I wanted to recognize, Liam, is that this was an open label trial, and we did it with all of the participants knowing what drug they were getting and what dose they were getting of that medication. And I guess I just was looking for your comment on, in recognizing that it's not a randomized controlled trial, and discussing where you discussed the natural sort of the natural attrition of symptoms associated with withdrawal from methamphetamine over that sort of that time course of a withdrawal syndrome. And I guess I was just looking for a comment around what you'd be aiming to do with an RCT to compare the intervention of lisdexamfetamine in that tapering dose regimen as compared to placebo. What would you be hoping to find, or what would you hypothesize that you would find in an RCT like that?
Yeah, so I mean, obviously the aim of any kind of withdrawal treatment is to reduce symptom severity, to ameliorate the withdrawal, whether that's through an overall reduction of symptom severity or maybe a more rapid reduction of symptom severity. Yeah, it's hard to say because we don't have good data on what this normally looks like. Which is definitely something that's lacking in the scientific literature around this topic. But But when we go ahead and do the RCT, it would be really, really great to see a significant reduction in withdrawal symptom severity compared with a placebo arm.
Right. So in that figure that you showed us, you'd have one group who were more either had a smoother trajectory along that first week, or who had less symptomatic trajectory as they declined in those symptoms.
Yeah, exactly. And I'm not really sure which way it'll go, to be honest, if there is any difference at all.
Mm-hmm.
But it could theoretically be one of those two ways, either lower on average or a more rapid decline in symptoms.
Great. And I just wanted to point out, because we did mention a few times about the smoke-free environment in the Gorman unit, in the detox unit at St. Vincent's. And so I just wanted to point out, though, that whilst it was smoke-free, it does offer NRT, but the NRT on offer does not include vaporized nicotine products. So that could be another difficult thing to navigate, I suppose. The idea that people were looking for a different alternative, perhaps, than traditional NRT.
Yeah, that's exactly right. And I did take the time to explain to the potential participants what NRT was on offer, how much they would have access to, which is as much as they could take. But it still wasn't enough. And they just really didn't think that they could get through the methamphetamine withdrawal without having access to their cigarettes.
Sure. Yeah. And do you see a possible place for this treatment, RCT permitting? In future, would you see that this could be something that could be translated to an out-of-hospital experience?
Yeah, absolutely. I mean, lisdexamfetamine has a very great safety profile. And we've managed to show in the Lima trial, which again, that hasn't been published yet, but we went through that trial giving it in an outpatient setting. There's definitely ways forwards using it for ambulatory withdrawal management, which is something that we'll hopefully be looking at in the future.
Great. And then the other thing I wondered if you could comment on briefly was what participants told you about their experience, particularly because I realized that we couch this kind of data and the literature around the idea that a withdrawal in itself is not treatment. A withdrawal is not necessarily going to translate to a longer term abstinence. But I am also conscientious of the fact that you don't make it to day 2 without day 1, and you don't make it to week 2 without week 1, or month 2 without month 1. I just wonder what the participants' perspectives were around that, because I know that you interviewed them in addition, which will be a separate DARIA session, hopefully in future, but just to touch on that briefly.
Yeah, absolutely. I mean, asking the participants what their personal experiences were like throughout the trial was really important. And I don't want to oversell it, because it worked really well for some people and it didn't work for others. But some of our clients reported that it was the easiest withdrawal they've ever experienced, and that they hadn't managed to go for more than one, again, great success story, can't generalize because it was one person, but he hadn't managed to go through more than 3 days prior to the study without using. He got through the 7-day admission for the OLAM trial and then remained abstinent for the 3 weeks following. So we can't generalize, we can't say it works, but for at least one person, it really did help. There were other people, of course, who didn't have the same response to the treatment. And once they finished with the OLAM trial, they went straight back to using. So it's quite diverse, but some people described it as really making the process easier. The cravings were less severe and the symptoms were less intense.
Yeah. And so, speaking of symptoms, we have a question from an anonymous attendee this afternoon, and this person is wanting to draw out a bit more detail about the potential medication rebound effect. So what was demonstrated, and what you demonstrated on your figure, was that on day 6 after the treatment completion, there was a bit of a rebound in those withdrawal symptoms. And this person on the chat is just wanting to know if that was supported by any physiological changes. So for example, was there any changes to the heart rate or the blood pressure? They're asking here, was the withdrawal experience gathered from subjective AWQ scoring from participants? And that figure that you presented, where there's an uptick, that was the AWQ, wasn't it?
Yes, exactly. So we looked at withdrawal severity using the AWQ. And of course, heart rate and blood pressure were objective measures taken. They were taken 4 times a day. So these are the average measures across the daily periods. But we didn't actually see any real changes in the physiological measures on days 6 and 7. And also, interestingly, we didn't see any uptick in level of craving for methamphetamine. It was only in the broader AWQ, which looks at a much wider series of questions, including things around sleep, general mood, appetite, things like that. So it was quite localized, the uptick, just in the AWQ scores.
Great. And so to the kind person who's submitted that question, if that didn't answer your question, or if you'd like further information, please feel free to type that into the Q&A box as well. I haven't had any takers to the Gorman clinicians. I know that we extended the invite to a few of them today, but I realized that this is a middle of the afternoon session. And I'd just like to remind everyone again that these sessions are recorded. They're available on the NCCRED website, so that's ncred.org.au. You can go back and look at the cataloged previous sessions, as well as sharing this session or anyone that seems of interest to you, your colleagues, consumers, patients, anyone who you feel might benefit from any of the information that's shared on these sessions. Please feel free to share those away. And if there's no further questions, I think I might. Oh, somebody's raised their hand. Craig has raised his hand. Shall we unmute Craig?
Hello.
Hey, hello. Good afternoon, Craig. So Craig is a senior staff specialist at St. Vincent's Hospital Alcohol and Drug Service, and had direct participant contact through the Gorman Unit Inpatient Withdrawal Unit for this trial.
So you asked about, clinicians' experience.
Yeah.
I guess I was doing what I normally do on a plane and not actually answering until the second call for a doctor.
Yeah, I think that's common experience probably amongst a lot of the people on this call.
And fighting with EndNote as I listen. So clinician experience, I mean, I was involved with a few, probably in the early stages and not afterwards. And once we worked out how to, sort of do the protocol, I mean, it was all quite straightforward, and the, clients seemed to have a good experience from my point of view. Yeah, it would be good to sort of see, I think, larger group and people who are randomized to either this or standard of care. So I don't know if we got a good feel for whether or not it's, decrease the use of diazepam or olanzapine in large enough numbers.
Mm-hmm.
But otherwise certainly safe. So,
Yep.
And yeah, I think, if it's sort of safe in the inpatient setting, it probably would be easy enough to do in an outpatient setting. We just have to sort of work out how to do it, whether it's a daily attendance or takeaway doses or what level of observation they would need.
Yeah, particularly because it is a tapering dose. And so there is a risk of, the idea of misdosing or accidental errors around that multiple tablets on one day.
We have modeling for what we do with alcohol withdrawal in our patients in terms of tapering doses.
Exactly.
Probably
Exactly.
A little bit different with this medication to a degree, maybe. I don't know.
Yeah, I think it is important to recognize other medications for other substances of dependence whereby somebody's in a withdrawal syndrome. I think there is some lessons to be learned from other substances that have been treated successfully, particularly by agonist therapies for going on decades. Yeah. I'm just going to unmute as well at the moment. I'm just going to also unmute Rob May. an addiction psychiatrist who also is a senior staff specialist or a staff specialist at St. Vincent's Alcohol and Drug Service, who is also involved in Gorman Unit patient care. So was also around during the participants who were enrolled in this study. Hi, Rob.
Hi, Krista. Hi, Liam. I thought I would just say something as well after Craig, because I had a few participants admitted when I was their AMO. And I guess, obviously the sample size is small, but I have to say, initially I was a bit dubious about the trial. I thought, why do we even need this? The patients come in and they crash, and then after they crash, which is more or less, the first day or two, like you say, and then it's a protracted, period after that. I was even wondering, like, maybe it would even prolong their sort of sense of withdrawal and make it worse. But the ones that I did see, they were quite comfortable, and they reported feeling looked after. They felt like the medication had really helped them. So none of those sorts of concerns I had actually manifested, and I thought it was actually, it was quite good to see and sort of track their progress through their withdrawal.
So do we avoid that crash phase a bit more, do you think?
It's an interesting point. And actually, in terms of that sort of further analysis and looking at this small, again, it's a small sample, n equals 10. We can't draw too many conclusions, but Liam actually does have some data around sleep, and participants in the study actually wore an actigraph for the duration of their inpatient stay. So stay tuned for future DARIA.
Well, no, that's important, because I think we when they do crash, we often don't interact that well with them in the ward sort of setting. And if it sort of does sort of prevent that crash to a degree, it might sort of increase their engagement with
that is actually something that multiple participants brought up of their own volition, which was that they could stay up during the day and do things, and they felt normal. Like more normal, they could do normal things. They could talk to people, they could interact, they could eat food and drink water and then sleep at night.
Yeah.
Which they thought was really important to their own recovery.
And so it gets them back into a normal sort of sleep cycle, sleep pattern a bit better, perhaps.
Yeah.
And did you find, Liam, that participants were receptive to meeting? I know that one of the things we do as treatment as usual is we offer to meet with an STP counselor, to meet with someone who could follow them up outpatient post discharge. And did you find that participants were receptive to that and had sort of the neurocognitive capacity to take that on?
Yeah, absolutely. Most of the participants, if they didn't have any kind of existing support structure already kind of waiting for them when they finished, were quite receptive to the idea of being linked up with long-term care services post-treatment. How well that ended up playing out and whether or not they actually engaged with them for a long period of time was outside of the scope of the study, because we only followed up with them for 3 weeks. But most of them were very happy to give STP a call and, kind of keep the ball rolling.
Right. So again, I think, in conclusion, this was a really unique opportunity to study a novel treatment. We had great support from the clinical staff, great support from the nursing staff, particularly in terms of, taking up a bed for a research participant and being amenable to all of the research protocols. I think, it'd be really exciting to see this replicated in an RCT. I'd love to see those figures with comparator lines. That'd be really exciting. And there's still clearly a lot of work to be done. This is one agent being tested for a pharmacotherapy for methamphetamine withdrawal, but there aren't really many others being tested at the moment. And so it would be really exciting to see this body of work expand in future. So again, I think I'd like to echo Liam's sentiments about thanking the participants, the staff, and the broader research team. And if there's no other questions for this afternoon, I think we can probably wrap there, and definitely keep your eyes and ears open for the future session, which will report on the sleep analysis of this sample. And also don't forget to share the calendar invites when they come through. Next week's session will be announced in a couple of days, and you'll see those calendar invites. And we look forward to hosting you again then.
Thanks, Krista.
Thank you, everyone. Have a lovely afternoon.